Hello, Study Nurse IQ family. Welcome back to the channel. I'm Jenny, and today we're diving into a high-yield GI topic you'll see everywhere in nursing: gastroesophageal reflux disease, or GERD. This condition is often misunderstood, but mastering its mechanisms will help you not only pass exams, but also confidently care for real patients. Stay with me until the end, because we'll wrap up with NCLEX-style questions to lock in your learning. Part 1. What is GERD? The basics. GERD stands for Gastroesophageal Reflux Disease. Let's break that down. Gastro means stomach, esophageal means esophagus. In simple terms, GERD happens when stomach acid repeatedly flows backward into the esophagus. Remember, stomach acid contains hydrochloric acid and digestive enzymes, both very corrosive. Since the esophagus isn't built to handle acid, this constant exposure causes inflammation and irritation over time. If reflux happens twice a week or more, we call it chronic GERD, and that's when complications start building up. Part 2. The role of the LES, lower esophageal sphincter. The main reason this backflow happens is due to a weak or damaged lower esophageal sphincter, or LES. Normally, when you chew and swallow food, it travels down the esophagus through wave-like contractions called peristalsis. When the food reaches the LES, a collection of circular muscles at the end of the esophagus, it temporarily relaxes to let the food into the stomach. After the food passes, the LES must snap shut tightly, creating a strong seal to prevent anything from coming back up. With GERD, that seal is broken. Part 3. Pathophysiology: why the LES fails. There are two main reasons the LES fails: increased pressure pushing upward, chemical relaxation weakening the muscle. 1. Increased pressure. Anything that increases abdominal pressure can push the stomach contents upward. Obesity and pregnancy: both conditions put physical pressure on the stomach and diaphragm. Overeating. Eating large, heavy meals dramatically increases the volume and pressure inside the stomach. Delayed gastric emptying. Conditions or medications like anticholinergics can slow down how fast the stomach empties into the small intestine. When food stays too long, the pressure increases upward. Hiatal hernia. This is a key trigger. In a hiatal hernia, the upper part of the stomach herniates or slides up through a weak opening in the diaphragm. When the stomach is sitting above the diaphragm, it puts constant, abnormal pressure on the LES, preventing it from closing properly. 2. Chemical relaxation. Certain substances can chemically cause the LES muscles to relax. Medications. Calcium channel blockers and sedatives are two classes you need to remember. Smoking. Specific foods: fatty and greasy foods, peppermint and spearmint, and alcohol. Part 4. The damage, complications of chronic reflux. Long-term exposure to acid leads to serious complications: esophagitis, inflammation and erosion of the lining; strictures, scar tissue formation that narrows the esophagus; Barrett's esophagus, cell changes that increase the risk of esophageal cancer; laryngopharyngeal reflux, LPR, acid reaches the throat and voice box, causing hoarseness, chronic cough, ear infections, and asthma flare-ups. Part 5. Clinical signs, symptoms, and diagnosis. The most common symptom patients report is heartburn, a painful burning sensation in the chest. This pain can be so severe that patients sometimes confuse it with a myocardial infarction or a heart attack. Always ensure a patient presenting with new or severe chest pain gets a cardiac workup first. Other signs and symptoms include a gastric pain, regurgitation, feeling food or acid come up into the throat, especially when lying down or prone; a dry cough that is often worse at night; dysphagia, problems swallowing or a feeling of a lump in the throat; subtle signs like chronic hoarseness or reoccurring lung and ear infections. Remember, not all patients have the typical heartburn. Some only have the respiratory or throat symptoms. Diagnostic tests. To confirm GERD and check for damage, physicians may order endoscopy. A scope is passed down the throat to visually inspect the esophagus for erosion, ulcers, narrowing, or cell changes. Esophageal manometry. This measures the function of the esophagus, specifically its ability to squeeze food down peristalsis and how well the LES is closing. pH monitoring. A small tube is placed to measure the amount of acid that comes in contact with the esophagus over a 24-hour period. Part 6. Nursing Interventions and Education. 1. Assessment Priorities. Pain quality. Is the pain GERD or cardiac? Assess the frequency and quality of the pain to differentiate. Respiratory status. Check for signs of aspiration or LPR, such as coughing, decreased oxygen saturation, abnormal lung sounds, increased respiratory rate, or worsening asthma. Triggers. Ask the patient, what foods make your symptoms worse? And use that information to develop a personalized diet plan. Medication review. Check their history for medications that relax the LES, calcium channel blockers, sedatives, or cause delayed gastric emptying, anticholinergics. 2. Patient education. Lifestyle is the treatment. We need to teach patients how to manage their lifestyle to decrease pressure and chemical relaxation of the LES. Meal timing and size. Teach them to eat small, frequent meals and avoid filling up on large meals. This reduces stomach pressure. Post-meal activity. Patients should sit upright for 1 hour after eating. Bedtime rule. The last meal of the day should be eaten at least 3 hours before bedtime. Lying down right after eating is a guaranteed way to cause reflux. Avoid trigger foods. They must limit or avoid foods that relax the LES or irritate the eroded lining. Greasy fatty foods. Alcohol and coffee. Peppermint and spearmint. Soft drinks. The carbonation increases stomach pressure. Acidic foods like tomatoes and citrus fruits juices. These irritate the already damaged esophagus. Other changes. Encourage weight loss if obese and smoking cessation. Surgical option. In severe cases, a surgery called fundoplication may be performed, where the upper part, fundus, of the stomach is wrapped around the lower esophagus to strengthen the LES. Part 7. Medications for GERD. Antacids. They neutralize the stomach acid so that when reflux occurs, it's not as erosive. Examples: magnesium hydroxide like milk of magnesia, calcium carbonate like Tums. Nursing consideration. Antacids interfere with the absorption of many other drugs. You must give them alone and separate them by 1 to 2 hours from other medications, including H2 blockers, PO antibiotics, and Carafate. 2. Histamine 2 receptor blockers, H2 blockers. Job: they block the histamine receptors on the stomach cells, which decreases the production of hydrochloric acid. Examples: famotidine, Pepcid, ranitidine, Zantac. Typically use short-term or on a PRN basis as symptoms arise. 3. Proton pump inhibitors, PPIs. Job: these drugs are the most powerful acid reducers. They block the final step of acid production in the stomach. They decrease stomach acid and are key to allowing the esophagus to heal. Examples: omeprazole, Prilosec, pantoprazole, Protonix. Mechanism: they attach to the proton pump of the stomach's parietal cells, essentially turning off the acid faucet by blocking the release of hydrogen ions. Nursing consideration. PPs are used long-term, but long-term use increases the patient's risk of bone fractures. Always assess the patient's bone density and fall risk. Prokinetics. Job: these drugs prevent delayed gastric emptying by improving peristalsis, the squeezing motion, and improving the pressure of the LES. Examples: metoclopramide, Reglan. Now let's test your knowledge of the material on some NCLEX-style quick quiz. Question 1. A nurse is providing discharge education for a client with GERD. Which instruction, if stated by the client, indicates a need for further teaching? Answer: I should take my last meal of the day right before I go to bed to prevent nighttime hunger. Rationale: the last meal of the day should be eaten at least 3 hours before bedtime to ensure the stomach has time to empty before the patient assumes a prone position, which increases reflux risk. Question 2. A patient is diagnosed with Barrett's esophagus. The nurse understands that this condition places the patient at an increased risk for... Answer: esophageal cancer. Rationale: Barrett's esophagus is the change of the esophageal cell lining, which is considered a precursor to a rare form of cancer and requires close monitoring. Question 3. Which medication, when taken chronically, places a patient with GERD at an increased risk for bone fractures? Answer: proton pump inhibitors, PPIs, such as omeprazole. Rationale: Long-term use of PPIs has been shown to interfere with calcium absorption, increasing the risk for osteoporosis and fractures. If this video added value to your nursing journey, please head to our YouTube channel, Study Nurse IQ. Click subscribe and share it with your classmates. Remember, understanding the why behind these conditions makes you a smarter, safer nurse. Thank you for studying with us. I'll see you in the next video.